I think before we call roll, we actually have some new members and some not so new members. So I'm going to ask our new members to introduce themselves, just your name, your affiliation, and I think we'll start with Dr. Sparkman. Yes.
Is this thing working? No, I'm Mark Sparkman. I'm an emergency physician out at San Antonio with the University of Texas Health Science Center, and happy to serve.
Hi, I'm Rohit Shanna. I'm an ER physician at Texas Children's Hospital and Baylor College of Medicine. Happy to come back on board. Thanks.
And we're happy to have you back, Dr. Shenoy. And Sandy?
And I am Sandy Williams. I'm the Trauma Program Manager for Children's Hospital of San Antonio.
Thank you. And we have one other new member, Cassandra Dillon, and we spoke by phone this morning. I think she's actually watching via the TTAF feed. So unfortunately, my emails have not been getting to her, and so we're going to try and get that corrected. But we're excited to have Sandy and Cassandra as well, and also always grateful that TTAF provides a live feed for these meetings. So Marianne, will you call roll?
Yes. Charlotte.
Here.
Susan. Yes. Marianne, I'm here. Wayne Dennis.
Here.
Cassandra Dillon. Courtney Edwards.
Present.
Jessica LaPlante. Dr. Shenoy.
Here.
Dr. Sparkman.
Here.
Sandra Williams.
Here.
Stuart Williams.
Here.
Are y'all related? Just making sure we don't have any conflict. Okay.
The minutes can show that was
That's true. Thanks, Marianne. First thing on the agenda is our liaison reports regarding TTAF activities and Texas Trauma Coordinators Forum activities. And Courtney?
So yesterday was the Texas Trauma Coordinators Forum. TTCF met, and in partnership with TTAF, we had the Capitol visit day where we coordinated visits with the legislators at the Capitol, educating them on the trauma system and emergency healthcare system here in the state of Texas and what we could do, and with further support financially, the release of the monies that we are rightfully own, and move forward with that and how we can do that. Also, there is a lot of bills that are starting to get filed, and one of the big ones is creating a statewide distracted driving bill, unifying some of the multiple cities and county ones that do exist currently, trying to bring them under one umbrella so that way they're all slightly different. So that was yesterday. The TTAF's Just Drive campaign is still ongoing. There's a lot of efforts in that. Discussion is actually beginning with the Texas State Emergency Nurses Association on unifying those efforts and moving forward, and having the ENA, the emergency room nurses, bringing on the Just Drive campaign. And there is still plans for the TIPS conference, which is the TTAF Injury Prevention Symposium, going to be offered the Monday before the meetings in August. It's going to be hosted at Dell Children's Hospital, and we're moving forward with that. The structure of that symposium is the first half of the day is more knowledge-based, getting a foundation. The second half of the day, we bring in individuals, programs, and they tell about their program, what their program is, how they implemented it, barriers and successes to that program. So that's going to be planned in August. We also, with TTCF, really starting the lead and starting to talk about this and then incorporating TTAF into that. Today we had a meeting this morning about the Trauma Survivors Network and bringing in our survivors to, one, assist us in the hospital and the acute care phase of the patient's rehabilitation process, getting them to talk about the event, offering those supports and those resources to address that mental component, that mental health component, as well as their physical component that we, the acute care team, are taking care of. So peer-to-peer interactions in the acute care setting, peer-to-peer in the community to offer that, and then growing our survivors. One, to offer their support in their mental health well-being and getting them the resources they need, but also to use them in an advocacy role in the future and helping, we're helping them, but also get them to help us in return. And so there's going to be quite a bit of work on developing a Texas trauma survivors network as well, resources for hospitals in which they can create and spur this in their own areas and communities, and then building upon some of the national resources that are already available through the American Trauma Society. So I think that's just a brief overview.
Thanks, Courtney. One of the goals of the Injury Prevention Committee is to continue to enhance the injury and violence prevention workforce in Texas, as well as support evidence-based programs. And so the TIPS conference or summit will be a good way to take advantage of this. It'll be here in Texas and at a low cost. And so we'll certainly be providing more information about that. Do any committee members have any questions from Courtney regarding TTAF activities or TTCF? Any audience, any questions from the audience regarding TTAF or TTCF activities? Okay. Well, the next thing on the agenda is I've asked Dr. Chris Drucker and his staff to provide a presentation on Texas Trauma Registry report, as well as the Texas Injury Indicators. And every year, CDC requests that the states put together information on injury indicators and things like that. And so, Dr. Drucker, are you going to do it, or someone else from your staff, or?
I was just going to introduce.
Okay, that's great.
You've done a great job already.
Hi, my name's Erin Cater. I'm an epidemiologist with the injury program at the state, and I'm going to give a brief summary of the state injury indicators report from 2012. So as you said, this is a report the CDC puts together every year, and our program provides data, provides the injury program. It's broken down into deaths and hospitalizations. So this graph shows the trends in death rates over the last 5 years. You'll notice data is missing for 2010. We did not submit data as a state in 2010, so you see a gap there. For most of the indicators, there's not a huge change in rate. Traumatic brain injuries is the top line in red, and so you can see there's an increase in the last year with that. Motor vehicle traffic fatalities are in the dark purple line. That also decreased until 2009, and then a slight increase again. So in 2012, there were 178,150 deaths. 14,592 of these were due to injury. These are all determined using death certificate data in the underlying cause of death codes listed on the screen. The overall injury mortality rate, age-adjusted rate for 2012 is 58 per 100,000. So this chart shows the injury deaths broken down by age group and sex. So you can see the age group on the left side of the screen, and the males are represented by the blue bars and females by the red bars. So overall, about 70% of injury deaths were seen in males, 30% were in females. The age group with the most number of injury deaths was 25 to 34-year-olds. So you can see there's a peak for males at that age and decreases again. Females is a little more even. It peaks in middle age and then again at the older ages. This table shows the different indicators measured by the CDC report. I want to point out that these are not mutually exclusive. A person can fall in more than one of these categories. So this shows the number of deaths for each indicator as well as the age-adjusted rate. So the causes with the highest rates were traumatic brain injuries, motor vehicle traffic fatalities, and suicides. This table shows the 5 indicators with the most number of injury fatalities for 2012 by age group. And on the far right, it has the total ranking for all age groups combined. So you can see TBIs, motor vehicle traffic, falls, and poisonings were among the highest ranking for most of the age groups. Now we'll look at injury hospitalizations. Again, here's the trend in the hospitalization rate over the last 5 years. Falls is that top line in green that dropped down in 2011 and then has increased again until 2012. In 2012, there were just under 3 million inpatient hospitalizations. 103,256 of these were due to injuries. These were determined by the ICD diagnostic codes listed on the screen. And these are all based on hospital discharge data, not the registry data. The overall injury hospitalization age-adjusted rate was 426 per 100,000. So again, here are injury hospitalizations broken down by age and sex. Males are the blue bars, females are the red bars. For hospitalizations, females make up just over half of the injury hospitalizations. For males, the highest age group is 15 to 24 and decreases, but for females, it increases up to age 75. Here's the table again showing the different indicators measured, the number of hospitalizations, and then the age-adjusted rate for each one. So for hospitalizations, the ones with the highest rate were fall-related hospitalizations, traumatic brain injuries, and motor vehicle traffic. So again, this table shows the top 5 hospitalizations for each age group, and again, the overall rank is on the far right. So falls make up the majority of hospitalization, followed by motor vehicle traffic and traumatic brain injuries.
Aaron?
Yes.
What's the red?
Traumatic brain injury,
Okay.
TBI.
Thanks.
Mm-hmm. That's the end of the summary of the indicator report. Do y'all have any questions?
Any questions from the committee regarding the injury indicators?
Would these be available for the public or anyone to access?
This specific presentation,
Yeah.
I can send it to you if you would like. The CDC, I don't believe, has published the indicator report for the year, but it will be available on the CDC's website as well.
Even before they publish, is it all right if we put this presentation on the DISH's GETAC website? Chris? Okay.
We'll be there.
Can you, sure, go ahead, Dr. Shinoy.
What databases did you use for this? Did you use the Commerce?
So for the deaths, we use the death certificate data from the death registry of Center for Health Statistics, and then the hospitalizations is based on hospital discharge data from the Center for Health Statistics as well.
And I couldn't see on the slide the top 5 reasons for death. It was
Okay.
on an earlier slide. I just didn't quite see that.
Please go back to that one. This table?
Yes.
Yeah, it's hard to see. So overall, the top 5 were traumatic brain injuries, and motor vehicle traffic, and suicides, and firearms, and poisonings.
Any other questions from the committee?
That right?
The other chart.
Oh,
No, sorry. The hospitalizations chart. Sorry.
that's okay.
That one?
Yes, thank you.
Another question is, so this is 2012 data?
Yes.
And what's the lag period before you get the next year and so forth? Like, you know?
It'll be around this time next year when we publish the 2013
Okay.
rates.
I think we all know that there's always, as much as we would like real-time data, and hopefully at some point in the future that will happen, there is a lag in injury data, and I know that CDC just put 2013 data on their Whiskers website, so. Any other questions from the committee? Does anyone from the audience have any questions for Aaron? If not, thank you. And I think the next report, we're going to talk about the trauma registry. And Dr. Drucker, are you going to do that?
Actually, that's the second presentation. The presentation is by Dr. Leon. She has a short presentation based on the 4 reports that the Injury Prevention Committee had made a request for.
Okay, thank you.
So as Dr. Drucker said, I'm presenting on the 4 reports that were recently submitted to everyone, the committee. And just before I start the summary, I did want to state that this is hospital data, 2013 hospital data. It was collected through a passive surveillance system, and the data representation of hospitalizations not individual patients. Inclusion criteria follows as per the Texas Administrative Code, Title 25, Chapter 103. So as a review, the 4 reports that were asked included all injuries by mechanism of injury with respect to demographic variables, intent, alcohol use, additional variables such as length of stay, several discharge variables, as well as total hospital charge. In addition, we also looked at falls according to the mechanism of injury, specific demographic variables, length of stay, discharge disposition as well. Lastly, we were asked to look at suicides, which is inclusive of fatal and non-fatal suicide attempts. And we looked at it with respect to demographic variables, comorbid conditions, and ED disposition. And this was all ordered by incident county, the 254 counties. The total number of hospitalizations in 2013 for our data, our registry, was 132,796. And all injuries by hospital charges reported in 2013 were in excess of $1 billion, with a median hospital stay of 2 days. This ranged from anywhere from 1 day to 10.5 days. The majority of individuals indicated that their race was white, 57.4%. 30.5% indicated that their ethnicity was Hispanic. This first figure is a histogram of the number of hospitalizations by age and by sex. And as you can see, the number of hospitalizations were particularly high for 2 distinct populations. Young men, which is on the blue side of the histogram, between ages 15 to 34, and older females, 75 and older. Yes.
And you also said that you told me the days, the number of days, it's 2 to 10 days?
Yes, the range was 1 to 10.5.
Okay.
But the median number of days was 2. Length of stay.
Okay, thank you.
This is a slide, a table that represents all injuries and stratified with fatal and non-fatal injury rates. The total number of fatal injuries identified in our registry was 3,828. As you can see, if you just look at the all injuries columns, the rates for the youngest and the oldest age groups were the highest, almost an exponential increase in the individuals 65 and older. Higher rates were observed in males and for individuals that indicated their race to be white. And these same statements could be made for fatal and non-fatal rates as well. What's interesting is if you look at rates for the fatal column, males were nearly 2 times higher than females. Looking at leading mechanisms of injury by the age categories. In the younger age categories, you can see that fall was a major mechanism of injury. Motor vehicle traffic injuries then take first place as you get into the teenage years. When you look at the older age groups, fall injuries then creep back into the first place as the leading mechanism of injury. We also took a look at intent. So for the next 2 slides, we looked specifically at unintentional versus intentional mechanisms of injury. Falls and motor vehicle traffic injuries make up the majority of unintentional injuries, nearly 76%. With regards to...
Sorry, can you go back?
Yes.
All right, so I'm assuming that the falls is all ages, it's not just older
Correct.
adults.
This is
so
of all ages and of all intents as well. Oh, sorry. intentional mechanisms of injury, the top two belong to cut, pierce, and firearm. They make up 66% of intentional injuries. If we look at fatal intentional mechanisms of injury, the top mechanism of injury goes to firearm, and the second mechanism goes to suffocation. Looking at fall injury data, the third report, a total of 61,550 fall injuries were identified in the registry. Of these, 1,339 were fatal. If you look at the rates in the age groups, in the younger age groups, males had higher rates up until about age 54, and then from then on, you see that older females have the highest rates of fall injuries. And this is inclusive of fatal and non-fatal fall injury rates. Lastly, the report on suicides was given. This is a slide looking at mechanisms of suicide by sex. As you can see, males disproportionately represent all the categories of mechanism of injury. This remains true for fatal mechanisms of suicide as well. Fatality rate for males was 19.4%, and for females it was 10.3%. So that concludes my presentation. If there's any questions regarding the data analysis or the data presented here, feel free to email me.
Actually, thank you very much for getting us this data. I think I just want to go back to Mary Ann's question, and just so that we understand this correctly. So you had 1 to 10 days it was the stay for trauma patients in the trauma registry. And I think there's some, because Mary Ann is at JPS, which is a level 1 trauma center. Did we hear that correctly? Because she obviously said she has patients that stay longer than 10 days, and I'm guessing that we do it at Parkland too. I don't know.
Correct. That was what the data showed. The range was 1 to 10.5.
So that's interesting, and I don't know how it falls out like that, because I mean, we have patients that are there forever.
Mm-hmm.
Right. So I don't know if it falls out because maybe.
Is it a reporting thing?
Yeah.
Or, yeah.
Is it us? How we
So,
fit in?
can everyone hear me? So this is actually a good point to bring up. What we're presenting is the data that we have in the registry. Thank you. What we have, oh wow.
You're on now.
What we have is the data that's in the registry. And we've discovered in other instances where what was thought was coming into the registry turned out to not exactly be true because of error either on the way data elements are mapped and reported to the registry, the way data is actually entered in. And we actually have a pretty good example to explain this in our main GETAC meeting on Friday. So this would be a good educational opportunity where we could now go back into the registry and say, hey, 10 and a half days does seem a little like it's cutting off part of the higher, those who stay in their facility a little bit longer. So what we can do is we can take the data we have for 2013 and take a look at it, and then I try to identify where there may be gaps if it's on the registry end, where there may be gaps on the way the data is coming in, or if there's gaps in the vendor. So there could be many different avenues. But this is one of those, I call them educational opportunities.
Yeah, absolutely. Chris, this was also 2013, correct me if I'm wrong with the timeline, was also the time frame where your big centers that do data files, there was problems with the vendors accepting those large file batches, and predominant data was those that did web entry, correct?
Correct.
Thank you.
So a lot of our larger facilities, at times we're unable to submit data to the registry because of the way they have the file formats. With our latest bill that was placed in production back in January, I'm specifically talking about XML file uploads, we now can accept that data. So that might be one of the many different plausible reasons why we have a range of 1 to 10.5.
Thank you very much. That's and I think this is also a good point to make in terms of the registry is only complete as to who reports and things like that, and so it's also a good time to encourage reporting to the registry, because the numbers, while they look large, that we know that they're underreported because not everybody has reported. So, Dr. Shinoy?
So, Dr. Rucker, so what's the gold standard you use to compare your trauma registry data with, in order to know that you've taken care of all these small problems, as you mentioned? Is there a gold standard you could use?
Well, for example, we know that we don't have complete compliance in reporting. We see that in hospitals, we see that in EMS. And that's not a new issue, but we're trying to overcome those different barriers that were preventing that data from being submitted to us. Now, in regards to the data itself, we are transitioning to the national standards. For example, in NEMSIS, we have a schematron file. It has to come in a certain way for it to be accepted. It's a rule file. And with the switch to 2014 NTDB, likewise, data is going to come in. Now, the gold standard for hospital data is NTDB. If we can match the data we have in our registry, the same facilities that submit up to NTDB, there should be no reason why that data doesn't match our data. If they're submitting the data up to the national organization, it should be the exact same data that comes to the state registry. And so we need to figure out where are the areas that that we need to identify if there's discrepancies in rules, if there's discrepancies in data elements, if there's discrepancies in which either the vendor or our registry has in accepting the data, we have to discover this. So there is a gold standard, and we're trying to seek after that gold standard to ensure that our registry data does match what is being said and what's being sent up nationally.
And I know that you haven't officially scrubbed the 2014 data, further data, but are you noticing in your reports that more hospitals are reporting that you're getting more information, more from EMS too, as we start to solve some of the problems with the registry, grow the registry, and also spread the word of those agencies that may not be reporting?
Correct. I know we're getting more data into the registry. If you look at the time frame from going back to where the registry started to where we are in 2013, where we are in 2014, even where we are right now in 2015, we see how historically we're now getting more data from facilities, and we are also increasing in the number of entities that are actually reporting to us. Are we at 100%? No. We need to get there, and we will.
I have a quick, is there a plan in place to do a comparison between the hospital or facility that is submitting to both locations? I know our registry goes to both locations. Is there a way that it can be compared to know if what you have in the state registry matches what has gone to NTDB?
This would be something that I would like to probably take up with to identify if that is possible. Standing right here right now, I do not know the answer to that question.
Because I think that would be a very valuable point. I agree. I think this is wonderful data to have, but as we all know, data is only as good as what it truly is showing us.
Correct.
So if we can find a way that we can indeed come to that gold standard or be able to verify and confirm that the information we are gathering is indeed correct, I think it would be worth taking that step. And I know there are several hospitals in Texas that are submitting to both locations.
Correct.
Chris, you mentioned just briefly about we're not at 100% of reporting, but and then you talked about like we're on the process of getting there. Can you talk a little bit about that process? What's the plan to increase compliance?
So any type of question, I'm going to have to defer to regulatory regarding compliance, because my office, my program deals with the data collection, running the registry. Compliance is a whole other program.
Okay.
Any other questions from the committee? Anyone from the audience have any questions for Chris? Seeing none, thank you very much.
Thank you.
I think what we're hearing is that the data is not perfect. There's still limitations, but there are steps being taken to improve and enhance.
Correct, there are steps. And one thing I just want to make notice is that we're now producing reports with the data that we do have. And so as we continue working together, as a GETAC council, as stakeholders, and as the state, we'll be able to produce these reports, produce annual reports that, one, mimic the gold standard, and two, can really emphasize what is happening in the state of Texas. EMS component, the trauma system component, for this committee, any type of injury. And that's where we want to be at. And I know we have the right team in place to try to get there.
Okay, thank you. Next on the agenda is, I think this is a good opportunity to introduce, for those who haven't met, the new State Fatality Review Team Coordinator. You're going to hear her speak in just a few minutes. I know that the Pediatric Committee usually asks for a State Child Fatality Review Team update at the quarterly GETAC meetings, and so I've asked Amy Bailey, who's the new coordinator, to also provide quarterly updates at the Injury Prevention Committee meeting. So, Amy?
Hi. I just have a few updates on some of the work that we're doing right now with child fatality review teams. One of the issues that we've been working on is drowning prevention. We created a drowning prevention work group starting in December, and we've met 3 times in December and January. This was actually a short-term work group to inform an RFP that we're hoping to put out in the next few months. We were able to collect information from around the state on drowning prevention activities and data from multiple sources, including Dr. Drucker, DFPS, some of the hospitals who are on the committee. And so we can get a good picture of kind of what's going on in Texas to inform the RFP that we're working on. Another thing that we have coming up is the Prevent Child Abuse Texas Conference. Child Fatality Review has a track at this conference, and so we're going to be holding a pre-conference session on Sunday, February 22nd. For anybody who would like to attend to have training on your Child Fatality Review team, there's going to be some great speakers. This will be in Las Colinas. And another conference in a strategic plan that we've been working on. We had a abstract that was accepted to the state's annual meeting on this strategic plan to reduce child abuse and neglect fatalities. Texas is actually pretty cutting edge with what we're doing. We were charged from the Select Committee on Child Protection to do a collaboration with DFPS and DSHS to form recommendations to reduce abuse and neglect fatalities in Texas. So that plan has actually been it's going to go public next week. So I'm hoping to be able to share that with you next week, a little bit more detail. It's a comprehensive plan on the highest categories of child abuse and neglect fatalities that they found. So.
Okay, thanks. Amy, any questions from the group for Amy? Any questions for Amy from the audience? Okay, thanks. Okay, next thing on the agenda is consideration and discussion about the implementation and evaluation of the hospital-based injury prevention components. And those of you who sat through our meetings last year heard a lot about this. This committee spent a lot of time in the bulk of last year developing these components for hospital-based injury programs. The document is available. It's available on the GETAC website. This committee met in San Antonio for a workday meeting at the end of January to discuss now the implementation of this document and the evaluation process of it. So I have hard copies. I only have 5 hard copies here. Again, it's available on the website. But the way that because we spend a lot of time talking about evaluation and the need to evaluate, we're putting our money where our mouth is too, in terms of saying, well, we spent a year developing this document, now we need to evaluate the use and the implementation of it. So our plan to evaluate this is several of the RACs. I know that Susan's RAC, and which one is that, Susan? L. And Marianne Ayers, E. And
P.
Sandy, P. And Stuart, what is yours? Okay. It's going to be, it's the availability of this document is being heavily promoted among those RACs. We were also hoping to promote it heavily among TTAF and TTCF. Our plan is our work group spent bulk of our meeting in January developing a survey questionnaire, simple questionnaire that will be distributed to the groups that are receiving the most promotion of this document. We anticipate doing probably a pen and paper a survey at the May meetings of these groups, as well as doing it again at some point in the future and then again in a year. And basically, some of the things that we're looking at are our hospital-based injury programs changing over time as a result of this document. Stuart, I don't know if you want to add anything to that, or I actually have a few copies of the draft survey available too, but Stuart or anyone else on the committee want to talk about the evaluation of the document?
I think it'll be a neat opportunity for us to really see if how this document is having an effect across the state. That's the point of the document, is really to help enhance our injury programs in the hospital sector. It gives you some basic stepping stones to start to build or further create those injury programs, to give some substantial resources for our injury prevention coordinators, our trauma coordinators, et cetera, and where to go to find those resources. As far as the evaluation, it was decided in the work group that we should solicit an IRB exemption in the event that we want to present or write a white paper or something of that sort about the evaluation of the document. And so we're attempting to figure out the process of that, working with our IRB folks to guide us through that process. And I don't think it'll take much to do that. And then eventually hope get the survey out there. I don't know exactly the mechanism that will do the survey. I think it might be a mix of paper and online. But really looking for a good compliance. Here we are talking about compliance again. And getting a decent response rate. So if you do receive the document or you receive that survey, please take 10 minutes to fill that out. It really does provide some feedback to us as far as the work that this committee is putting together and attempting to help that injury sector across Texas. It informs us as far as whether this is a useful tool or not. So.
Sure, Susan.
I just wanted to add that I'm very proud of the fact that as we worked on this document, we attempted to make it something that is user-friendly and user-friendly at all levels. This is not information that's only going to be good for those large metropolitan centers. It's going to be good for our facilities that are smaller and rural and don't have the dedicated staff. So we tried to come up with an across-the-board approach that would truly be beneficial to everyone. And we're only going to know if it works and it's successful if y'all give us feedback. So we would really appreciate you taking the time to look at the document and give us suggestions or guidance on things that we did right and things we might improve.
That's a good point, Susan. And we often say this is a living document. This doesn't mean that it was created and that's, you know, this is going to be the end all be all. For injury prevention to strengthen in the state of Texas as well as nationally, we need to be making constant changes and continuing to assess our situation at the time and the environment. Did you?
Do you want to just touch on where it's going nationally, perhaps?
Yes, please do.
So recently, many of you hear us talk about the Safe States Alliance. and the network that the Safe States Alliance provides, a national platform for injury and violence prevention individuals, professionals, excuse me. Within that association, the Alliance, the Hospital-Based Injury Prevention Special Interest Group has taken this on as an agenda item. It has developed a lot of interest. There's a tremendous amount of talk about enhancing injury programs nationally in many different organizations, not just Safe States Alliance. The American Trauma Society is talking about it, Society of Trauma Nurses, the COT, AAST, ENA, East, all of, I mean, there's a lot of conversation about injury prevention and what's happening in the hospital sector around that. So through the Hospital-Based Injury Prevention Special Interest Group, there was an actual recommendation put together and sent to the executive committee at Safe States Alliance to attempt to convene a comprehensive group from many of these organizations to have a national conversation about how do we implement or how do we build a guideline using this as a basic outline to build off of for a national guideline for and providing resources nationally to how to build an injury program in a hospital environment. So we'll keep you informed as far as where that goes, but you can also become members of Safe States Alliance and join into the conversation too. So.
Also, what they said is really true, and we passed it out at our RAC 2 times now. But also, if you think about where you are right now in your facility, how many of your administrative people know what you do? How many of your administrative people understand the value that you provide not only to your hospital but to your community? Does your vice president of your hospital, your organization, know even what an injury prevention person is? And so many times we're so busy doing what we do that we don't advertise how good we are and the effort that we go to. So one of the first things I did when it was all officially final is I stuck it in a binder and I sent it up to administration with a little letter saying, here's what I do. And they're like, oh, that's pretty cool what you do. And I didn't tell them that my goal is to put us out of business as a trauma center. But, so use that for your own benefit, for your trauma service, your department, to highlight a positive. So many times we think of trauma as so yucky and it's not pretty, and what we do is. So use that. Very scientifically stated.
Thanks, Marianne. I would just add that not only is it a chance to promote what a trauma coordinator, an injury prevention program coordinator does, it's also a document that's meant to be something that you could use as a tool to take to leadership to say, this is why we need money for this. This is why I need to attend this training. This is why. And so part of the purpose is for you to be able to use it as a tool. Courtney?
And we keep mentioning all these different organizations. We're actually all together talking. They are all together. The AAST, the American Association for Surgery and Trauma, convened a group that brought in the Society of Trauma Nurses, that brought in the Trauma Center Association of America, brought in the American Trauma Society, brought in Safe States. They were all in a room. They were all talking together. The American Trauma Society is going to own an injury prevention course that was created with involvement from many of these people involved in these organizations. The pilot is going to be in April in conjunction with the Society of Trauma Nurses annual conference in Florida. We will have engagement and involvement in that organization. We will have an individual come back to us here in Texas, report out that information, tell us about how that course is going. And that's their trial one. It's going to be evolved, but it's taking in many of these components and everything that we're talking about and bringing it together. The hope with that course also is to have the real core, people in the classroom, butts in the seat, type of education. But then when you leave that, to have ongoing distance education, to have webinars that will take you and continue to advance you to a more, there's all these courses out there for when you're starting, but when you're really ingrained in something and that's what you do, there's very little to help take you to that expert, platform. And so developing online education to take you from that novice and intermediate person to an expert.
Thanks, Courtney. Any questions? Any questions from the committee? Other comments? Any questions from the audience? All right, this is probably a good transition to talk about national and state injury prevention opportunities, and I'm going to ask Stuart to do that. And Colin, the next thing on the agenda is an update on the Injury Free Texas website. So since you're sitting next to the computer, will you go to www.injuryfreetexas.org and we'll pull that up next.
So I'll give a brief overview of some of the national state injury prevention conferences that I know about. There may be a lot more, I'm not sure. As far as in the near future, right in our own backyard in Dallas-Fort Worth, March 11th through the 13th is the National Drowning Prevention Alliance Water Safety Drowning Prevention Conference that's happening. Several Texas organizations are presenting there, and it's completely focused on drowning and water safety prevention. That's March 11th through the 13th. The National Lifesavers Conference for Highway Safety is happening in Chicago on March 15th to the 17th, very targeted at transportation issues, motor vehicle crashes, pedestrian and bicycle injuries, distracted driving. All of those concepts are presented there. And it's a very informative, very large conference. If you've not been to Lifesavers before, it's definitely worth the trip. And then here in Austin, there is the National Safety Council, which is convening a community safety summit, and that will be March 30th through the 31st. And from what I understand, there is a discount code. If you register shortly, it is HLFOFF, which I think stands for half off, minus the A. And that'll happen on March 30th to the 31st. It has been promoted nationally, and I don't know what the makeup of the attendees will be, but it should be an interesting a summit. And I believe the second day of that summit is an organized Capitol Hill visit with representatives, et cetera, that's being planned. And then the last national conference that I know of is the Safe States Alliance, Creating a Culture of Safety, It Takes All of Us conference. That's happening on April 29th through May 1st in Atlanta, Georgia. And that should prove to be a very interesting, very, very informative conference. And I know that there's a slate of really wonderful speakers. I think the COO, president of JPS, is presenting there. And so we have some representation from Texas that's actually providing keynote addresses there. So I would encourage your participation in that as well. I think that's all I have, unless others have more.
Just the one that Courtney was saying, that the newest course that's put on by all the 10,000 and acronyms of groups, East, STN, everyone. It's March the 28th and 29th. That's a Saturday and a Sunday. It's 2 full days, and it's the inaugural course for injury prevention coordinators, hospital-based predominantly. So we're going to go scope it out.
And that course, just to capture on what Courtney and Marianne said, it is supposed to be designed around an injury prevention coordinator that's new coming into the position to help them really answer the Green Book or Orange Book ACS verification requirements for injury prevention.
Dr. Shinoy?
One thing I want to share with the group is the ongoing course for child passenger safety technicians. It's really a good course. It's heavily underwritten, so it's practically free of charge. I know in the last week, Greater Houston area had one. It's a 5-day course, and basically you learn everything about installing a safety seat, all the liability issues, as well as what to do with recall notices. And once you're a technician, you can actually do it in the community, and in order to keep your skills, you have to do at least 1 or 2 classes a year. They've rolled this out from a hospital to several places, the sheriff's offices, etc. And I think it's a great way to mushroom all our skills and knowledges. So I'm just sharing that with the group.
Dr. Sparkman? Oh, you didn't? Okay. Stuart?
I forgot one other. It's a highly sought-after course put on by Johns Hopkins. It's the Summer Institute. It's actually, there's 2 different parts of this course this year. There are 2 different courses, actually. The first one is the Principles and Practice of Injury Prevention. That is May 31st through June 3rd. Registration opened February 13th. Again, that's Principles and Practice of Injury Prevention, May 31st through June 3rd. That's in Baltimore, Maryland. A very informative and sought after for injury prevention professionals as far as some of the, it's kind of like the basic training course for injury prevention professionals. Very put on very well, and it also equates to, I think there's an opportunity for it to provide college credit if you're in college and you're looking for an additional elective credits or something of the sort. The second part is a course called Demonstrating Impact with Mixed Methods Program Evaluation, and that follows the principles course on June 4th and 5th. It's a 2-day course. Again, Demonstrating Impact with Mixed Methods Program Evaluation, June 4th and 5th.
Thanks, Stuart. And then just one other conference that I'm sure everyone wants to put on their calendar is September, October-ish of 2016. There is another World Injury Conference being planned in Finland. So,
Get ourselves there.
exactly. Exactly. Okay. Next thing on the agenda is just an update on the Injury Free Texas website. This is something those who attend these meetings regularly have also heard us talk about. This is something that is being provided to Texas by the University of North Carolina's Injury Prevention Research Center. They're one of the funded injury control research centers by CDC in the U.S. And they did this they did an injury-free North Carolina website, and their plan is to try and do it for most states. Texas just happens to be the next state that they worked with. This includes information about evidence-based policies, so it's very policy-oriented. You're not going to see a lot of programmatic information on there, but I think it's particularly pertinent because Texas's legislature is only in session every other year, and so this is a great resource to be able to direct policymakers, others to. It's very topic specific. It is not complete as of yet. I think if you click on like the transportation, I think you'll see that the things regarding distracted driving and teen driving and things like that, those sections are complete. The ones that are incomplete are like unintentional drug poisonings, but it directs you to a CDC website or an appropriate website. And encourage you to look at that. If you have comments, feedback, please direct them to me, and I'll make sure that it gets communicated to the University of North Carolina's Injury Prevention Research Center, and we get appropriate changes and edits made. So are there any comments about that, Miriam?
So have y'all downloaded or ordered your Orange Book yet? So if you look in our chapter, the injury prevention chapter, I say our, like ours.
Chapter 18.
Good, yeah. It's the best chapter in the book. If you look in there, the things that I was comparing the green book to the orange book, we're having our survey in a couple of months. I was comparing the green book to the orange book, seeing what I need to be looking for, changes in my role. And it goes right along with this website because there is quite a bit of criteria. There is criteria deficiency if you are not involved, especially they want you to be involved with legislation. They want you to be involved with policy making because we know that if there's a law, you know, people are more apt to comply, change their behavior, you know, just the same things that we were at the Capitol talking about. So it really, this website is a great tool to use as you move forward, looking at the new Orange Book and all that we get to do. So, thank you.
Any questions? Okay, next thing on the agenda, the next two things are review and update of the strategic plan for the Texas EMS and trauma system and accomplishments of this committee since its inception. Those are two things that the big GETAC Council asked us to provide following the August 2014 GETAC meeting, and this committee did that. I know that I think it gets continuing to be added to this because some committees haven't done that yet, but we're going to defer those two items on this agenda until we get more direction from GETAC, and I believe that's on GETAC Council's agenda to discuss on Friday. So we'll provide more input following decisions of the GETAC Council. I'm going to open it up now for announcements. And first announcement that I have is that this committee usually has workday meetings the month before our regular GETAC meetings, and so we met in San Antonio. Thank you very much, Sandy, for hosting our January workday meeting. We have our next workday meeting will be in April at Texas Children, and Dr. Shinoy will host that. It will be April the 24th from 9 a.m. until noon. These are all open meetings. The agendas are usually posted a few weeks in advance, but anyone and everyone is open to attend those meetings. So if you're interested, April 24th is our next workday meeting. So I know that we have several announcements, and Dr. Shinoy, I'm going to call on you first to talk about possibly your drowning study and.
So this is just, we recently published an article in Injury Prevention on submersions in Harris County, Texas. And what we found was that, as you know, like 70% of drownings occur in swimming pools. And there was a 28 times higher risk of submersions in children who were in apartment complexes as compared to those in private homes. And so that was one. And then we also found that it was spatially, we could spatially map it. And so what's interesting is now we've gone to the next step where we're actually doing an apartment survey, actually visiting these sites. So it all started from 2003, and I recognize some people here, Carrie Kane from UT Houston. We formed a group. We worked with the City of Houston, EMS Systems, the Child Fatality Review Team, got all our data together, and we've got now running data until present. So I think this is a way in which you can actually make an impact on the local level. So I just want to share with you.
And then also, you might mention too, Dr. Shinoy, that many of you remember that the Texas Children's Hospital Association, did I get that right? Yes, put together a report on injury prevention, pediatric injury prevention activities in the state. And they presented, I believe, sometime last year. And as a result of that, one of the things that Dr. Shinoy is also looking at is trying to get a handle on involvement, coordinated efforts within the states between RACs, Safe Kids Coalition. So do you want to talk a little bit about that?
So I'm part of also the Emergency Medical Services for Children, EMSC, state partnership grant, and that's currently being run by Baylor College of Medicine. Sam Vance, who's in the audience. Sam, can you put your hand up, please? So Sam's the coordinator for that. we have, among the different parts of what we have to perform, like performance measures, one of them is injury prevention. And so regarding the children, what we're trying to do is there's a very good, robust partnership with the Safe Kids Coalition. There are about 10 in the state of Texas. And what you're trying to do is at least have them pair with the RACs in that area. There's a lot of commonality. They're doing the same work which all are doing, and why not share the resources for those with successful partnerships? Example is like in Temple, Susan's got something up and going. We have it in Houston as well, with the RACs as well as that. And I think in Austin area, Stuart sits on both the committees, I think. Yes. 2 hats in one. So that's what we want to share with, and we're going to be trying to contact you all to get your contact information so that we can set you all together. So that's what I wanted to share.
Okay, thank you. And speaking of EMSC, I have actually asked Sam to start providing updates beginning at our May regular meetings. So we'll be hearing, in addition to the State Fatality Review Team updates, we'll also hear from EMSC regularly. So we look forward to hearing about that. The other thing that I might mention is because this committee is interested in promoting evidence-based programs, activities, and things like that. And Jennifer Northway and I had the opportunity to sit in on the Safe Kids Austin meeting this morning, right before this one, and learned a little bit more about a program or an initiative that I'd heard about nationally called Vision Zero. And I'm thinking, I don't know, Stu, if you want to add anything to this, but I'm thinking this would, maybe for our May meeting, we could get Robert to come in and talk about Vision Zero and provide some information about that.
Yeah, I can invite him. Absolutely.
And Vision Zero is an initiative to, it basically says that as statisticians, a lot of us say, well, we can't be perfect and we can't prevent all deaths and things like that. And Vision Zero is taking the approach of why not? What they would like to see is a 0 deaths regarding transportation, whether it's bike, pedestrian, motorcycle, motor vehicle, and things like that. And they're starting to look at a very comprehensive, inclusive approach to making sure that that there are 0 deaths regarding transportation. And one of the slides that he used I thought was priceless in terms of, we know human behavior is imperfect. Human behavior will always be imperfect. What can we do in terms of engineering and policies and things like that so that when the human behavior makes a mistake, it is not a fatal mistake? So we look forward to hearing about that.
Yeah, I'll extend an invitation.
Okay. Any comments, any announcements or suggestions from the audience? Linda, welcome back.
Thank you. I just wanted to say hello to everyone. My name is Linda Jones, for those of you who don't know me, and I'm back. And I'm back with wonderful colleagues at the Health and Human Services Commission Office of Acquired Brain Injury. So I just started in January. Gabby started in February, and Princess, our manager, started in August. So we're kind of like really gearing up and getting rolling. And I wanted to let you know that March is Brain Injury Awareness Month, and March is like just a few weeks away. So we are furiously working on some fabulous posters and concussion cards, and we'll definitely be in touch with you and hope that you will help us promote the idea of prevention of brain injury. So it's great to be back, and I hope that maybe another time we can talk to you all and let you know some of the exciting projects that we do have going on.
Absolutely. We'll be sure and let's talk after the meeting, Linda.
Okay.
Maybe we can get you added to the agenda as well. And this is very exciting to hear because one of the pieces that is currently missing on the Injury Free Texas website is information about evidence-based concussion policies and things like that. And so that's next on our list to do. So
Great.
Thank you very much.
Great. And I also wanted to give kudos to the staff of the Trauma Registry. Carry on. Okay. Thank you.
Okay, any final comments from the committee? Any final comments from the audience? Okay, I have to note that somebody forgot to punch our little time clock that I'm looking at.
You're fine.
But we are going to forget about that and actually end this committee meeting early. We will see you, hopefully see you in April in Houston or in the next meeting in May. Thank you. Meeting's adjourned.